let's start our first session in surgery. It will be two sessions, today and tomorrow at the same time, so we can take as much as we can in surgery. So let's start. We have 65-year-old man is evaluated in the hospital for acute onset shortness of breath. But let me reassure, the voice is good, right? You see the PDF. If there's any problem, just let me know. Okay, so let's continue. We have here, okay, sorry. Yeah, okay. So we have 65-year-old man is evaluated in the hospital for acute onset shortness of breath. The patient was originally admitted 5 days ago for peritonitis for perforated peptic ulcer, for which he underwent a surgical repair. A large bore, a right internal jugular venous catheter was placed during the operation. Okay, so we have a CV line, what we called it. This is jugular venous. Today, he was out of bed, sitting in a chair, and comfortable on room air. The internal jugular catheter was removed. Minutes after catheter removal, the patient develops acute onset shortness of breath and cough. So we have something related to this jugular catheter. Okay, about the surgical and perforated all distraction. Okay, from here we can say that the case starts. Minutes after catheter removal, the patient develops acute onset shortness of breath and cough. On examination, he appears in respiratory distress, blood pressure good, pulse good, respiration good, but oxygen saturation very low. The jugular veins are distended. Breath sounds are normal and equal on both sides. Be careful when you see like this, breath sounds normal and equal, so no pneumothorax. Okay, so we have something related to jugular catheter removed, but not pneumothorax. In addition to high flow oxygen supplementation, the patient should be immediately placed in which of the following position. So because we have this removal and low oxygen saturation, so this is air embolism. Okay, and the best situation is the lateral decubitus. Okay, why? I will tell you. We have venous air embolism that comes with trauma or certain surgeries or central venous catheter manipulation, or we have barotrauma like PPV or positive pressure ventilation. We have sudden onset respiratory distress with hypoxemia and obstructive shock with cardiac arrest. When you see like this comes together with these etiologies, so this is venous air embolism. The most important thing is left lateral decubitus positioning or high flow or a hyperbaric oxygen. So just in the bold, we have sudden onset respiratory distress. After removal, central venous catheter. This is venous air embolism. This causes obstructive shock and at the end cardiac arrest. Okay, so the best way to put this air, after that we put the heart in this lateral decubitus. For the air embolism, we can trap it in the right ventricle. Okay, so because in the normal heart anatomical position, this air embolism could be close to the aortic, so it will close this aortic and could cause obstructive shock and after that cardiac shock. But if we see it in this decubitus, we can trap it in air embolism. Okay, so we have after removal, the air comes to the right atrium and after that to the right ventricle. So we trap it here before, or to be careful that this embolism could close, or sorry, could be close to the pulmonary artery or arterial artery or aortic or artery, sorry. Okay, so this is very common cause after surgical maneuver. So another one, we have 29-year-old woman comes to the office for worsening pain in her right knee. The patient has had increasing knee pain and swelling for the last 3 months, which has prevented her from going to her weekly yoga and running on the weekend. So we have knee pain and swelling. She has tried taking ibuprofen and putting ice on her knee, but these have provided a little relief. The patient no chronic medical condition, no tobacco, alcohol, no fever. On examination, the right knee, mild soft tissue swelling, no fusion, but with decreased range of motion. When you see like this, the first thing you do to do X-ray. This is the easy one and economic one. X-ray shows an expansile lytic lesion at the epiphysis of the distal femur, as shown as here. Okay, this is the picture. Okay, so complete blood count and serum chemistry is all normal. Which of the following is the most likely diagnosis in this patient? So we have this swelling and this chest X-ray. So what this is it? This is it. Don't forget it. This is giant cell tumor. Okay, this is very indicator for this case. Don't forget it, like the bubble. Okay, like it's a bubble, and we have lytic. So this is giant cell tumor. Okay. What about another one? We have a 42-year-old woman comes to the office for evaluation of a mass at her right wrist. The patient first noticed swelling in her wrist a few months ago after spending a week knitting blankets for her family. The mass has not caused any pain. Be careful when you see like this, no pain, or stopped her for participating in a daily activities, but it continues to slowly increase in size. So just we have this swelling or white mass without pain. Medical conditions, we have hyperlipidemia and RA. Medications, methotrexate for RA and statin for hyperlipidemia, and occasionally ibuprofen. Vital signs good, BMI a little bit high, but we have slight ulnar deviation at both wrists with 2 centimeters mass on the extensor surface of the wrist. Without skin discoloration, the mass is firm, mobile, non-tender palpation, and transilluminates on pen-light examination. This sentence, it's obvious for the diagnose. When you see transilluminates, so this is just fluid, just mass with fluid. So what is the diagnose? It's an easy one. When you see like this, so this is ganglion cyst. Okay, it's not epidemiod. No, this is a ganglion cyst on age. We see it in the extensor of the hand. Okay, this is it. So this patient, sorry, with a mobile non-tender swelling on dorsal surface has a ganglionic cyst. Okay, on the rest you see it, and the transillumination. Most ganglion cysts resolve spontaneously and require no treatment. Okay, just a few patients. It could be painful and persistent symptoms. Options include aspiration and surgical excision. What about the other choices like epidermoid? No, because it's small, less than 1 centimeters. Here we see it bigger. This is free mobile nodules with central punctum. This is on the palmar surface of the digits. This is the epidermoid. Okay, the place is good. So we have two things, small and the palmar surface of digits. Lipoma, no. This is because lipoma, not this found. We will see it in subcutaneous tissues, not here. Uh, we see it on trunk, shoulders, etc. About RA, no, because RA in the olecranon, sorry, all dorsal forearm. But this RA not transluminates. Okay. About the xanthoma are also not transluminates. The transluminates are very important to be honest with you, the epidermoid and the ganglion. Okay, but must fit with ganglion. Okay, so before we continue, if you have any concerns or problem or questions, just let me know. Okay, okay, so let's continue. We have here a 40-year-old man comes to the emergency department due to worsening right lower abdominal pain that radiates to the right groin area. He has had the pain for the past 7 days and it is slowly increasing. Okay, so we have pain in the lower to the groin. Thus, in the last 7 days, he also describes fever and anorexia. When you see like this, looks for fever for 7 days, looks for infectious problem. Okay, don't forget it. Fever means infectious. 2 weeks ago, he was treated for flancolososis of the right thigh, by meaning skin problems for the hair follicles, etc. The patient has a history of type 1 and takes insulin, temperature high, abdominal examination with C tenderness on deep palpation in the right lower quadrant without rebound or guarding. So this is not appendicitis. Okay? We don't have rebound or guarding, just deep palpation is painful. No masses, bowel sounds good, but look for here. This is the indicator for the solve or for the answer. Extension of the right hip increases pain and flexion decreases pain. This is what we call psoas sign. When you extend the hip, that increase the pain, but flexion decrease pain. Rectal examination, no problem. Skin good. Hemoglobin good. Platelet, everything's good. Which of the following is best next step in management? Because we have infectious site like bronchiolitis, and we have fever, and we have the psoas sign. So the most important thing to do is CT scan of abdomen and pelvis. Okay, this is very important just to look for psoas abscess. Okay, let's talk about this. We will see subacute fever and abdominal pain, radiate to groin or hip with anorexia, weight loss, and abdominal pain with hip extension. This is psoas sign. The diagnosis is CT scan for abdomen and pelvis. You can see leukocytosis, elevated inflammatory markers. Most important thing is blood and abscess culture. The treatment, draining. For that, we take here surgery. Okay, so the treatment is draining. About, in addition to that, we will give broad spectrum antibiotics. So we have history of skin infections who presents with fever, pain, radiating to the groin, likely has a psoas abscess. Okay, so this is a subacutely psoas sign with hip extension. The most important things is to do CT scans. Okay, we talk about the bald line. Okay, here we'll see this. This is the abscess on CT, closer to the kidney. Okay, so this is the psoas abscess. Don't forget it. Okay, on every exam they always give you an pictures in iPhone and USMLE. All these exams give you like these pictures. Be careful. Okay, what about testicular cancer? The epidemiology, we'll see it between age 15 to 35. We'll see it with family history and the cryptochidism, by meaning missing testicular in the sac. Okay? About types, the most common one is germ cells tumor. It could be seminomatous or non-seminomatous. Okay? The non-seminomatous, like carcinoma or XAC, etc. It could be the 5% is sex-cord stromal tumors, stertoli, Leydig, etc. Leydig and sex cord could cause or could has the beta HCG. Don't forget it, okay? We'll see it unilateral, painless, testicular mass with dull ache in lower abdomen, okay? Testicular cancer, most of you know it, okay? But this dull ache in lower pain, could forget it. About the diagnosis, just examine. We'll see firm ovoids, okay, like a worm, by meaning ovoid mass. We'll see elevated tumor markers like AFP, PTHCG, LDH. The most important one is scrotal ultrasound. We'll see this mass with irregular border, etc. So this is testicular cancer. A very important one, very recurrent case. You'll see it in the surgery part. We have 30-year-old woman comes to the office due to pain over the lateral side of the right wrist over the last 4 days. She is a 6 weeks postpartum for her first child, and the pain is most severe when she lifts the infant from the crib. The patient has not had acute trauma or wrist or hand. Vital signs good, so no fever, no infectious problem. Okay? Examination, we see tenderness over the radial side of the wrist and first dorsal compartment, by meaning the lateral part, with the hand in a fist and the fingers closed over the thumb. This passive adduction reproduces the pain. I will repeat: hand, fist, and fingers closed over the thumb. Okay? This passive abduction reproduces the pain. We'll see a picture like this. So what is the diagnosis? Okay, it's not trigger thumb, no scaphoid fracture, no osteoarthritis, no flexor. This is decarvan after a huge elevate or using a lot of hands. So this is decarvan tendinopathy. This sign he give you to know the diagnosis. This is decarvan tendinopathy. When you use the hands a lot, this extensor, okay, retinolacum will affect the tendon sheath and the extensor for pollicis and abductor, and that could cause this pain. Okay, so we have the lateral wrist pain. So this is the Carvan. Okay, the sign he gives me, this is a Finkelstein test. Okay, this is one. He put the fist and the thumb below the other fingers, and we do this stretch test. This could cause the pain. Okay, we have also anatomic snuff box pain in this area, okay, in this lateral on the wrist. Okay, this is also scaphoid fractures. Okay, choice D. Scaphoid fractures comes with forceful hyperextension of the wrist, by meaning fall on a straightened hand. We'll see pain and tenderness localized to this anatomic snuff box. Okay, it's not like Finkelstein test. It's not like because we have pregnant woman. Okay, the pregnant woman meaning lifting infant, etc., and that could cause decarvan tendinopathy. Okay. Okay, so let me see if there's any problem. Okay, please, if you have any problem, just let me know. Okay, so we have here a 45-year-old woman comes to the hospital for elective cholecystectomy. The patient has had postprandial upper abdominal pain and nausea for the past several months. An ultrasonography revealed gallstones. After discussion of risks and benefits, we do laparoscopic cholecystectomy was planned. Okay? Her medical conditions include obesity and hypertension. All we talk about is distraction. Here starts the case. Okay? All distraction. Don't waste your time to rereading it. Okay? Always look for the keyword important. In preparation for the surgery, general anesthesia with endotracheal tubation is administered. Immediately after a needle is placed into the interperitoneal space and CO2 gas insufflation is performed, we see severe sinus bradycardia and transient atrioventricular block is noted. Which of the following is the most likely cause of this observed intraoperative finding of this patient? So just we give this space and gas CO2, we see the bradycardia and transient atrioventricular. So what is the cause of that? We'll see it because of peritoneal stretching. Okay, just like that, an easy one, but always memorize it because we work on the abdomen, and that peritoneal stretching will cause the bradycardia and transient block. Okay, so let's see it. We see here laparoscopic intervention is a minimally invasive option for a number of intra-abdominal surgeries. Okay, but the preparation requires insufflation of CO2 to create space for surgical maneuvering and facilitate the camera during the procedure. CO2 is introduced to the abdomen via needle or port with continuous monitoring in intra-abdominal pressure. But peritoneal stretch receptors sense the increase in intra-abdominal pressure and respond by triggering the increased vagal tone. Okay? So, close monitoring because these patients may develop severe bradycardia, interventricular block, and could cause a systole because of increased vagal tone that related to peritoneal stretch receptors. The increased pressure can also could cause mechanical disease, in systemic leading to elevations in blood pressure. But we see here the problem is bradycardia. Okay, what is the related to bradycardia? This peritoneal stretch receptors. The other choices are not related by meaning CO2 gas immobilization. No, it's not a rare one, not related to severe bradycardia. Agents for general anesthesia like propofol could cause cardiac suppressive, okay, but inadequate anesthesia could cause tachycardia, not bradycardia. Okay, about absorption of abdominal CO2, it's not related to also that. Could cause peripheral vasodilation, the absorption, because CO2 is vasodilated agent, and we'll see a reflexive, increase in heart rate, not decrease. About vena cava, no, it's not good cause at all, because in addition to that, if there is vena cava compression, that will cause increase in heart rates. Okay? Because if we know blood by meaning to heart, that could cause increase in heart rate, not decrease. Let's revise the esophageal cancer. It could adenocarcinoma or squamous cell carcinoma. The adenocarcinoma happen in the distal, okay, arises from Barrett, okay, after a long time GERD, or it could be squamous, cell carcinoma, and that happen in the proximal or mid, and that's related to smoking. About risk factor, we talk about it: GERD, obesity, male for adeno, smoking, alcohol, or n nitrosol containing for squamous. The symptoms: progressive solid food dysphagia, GI bleeding, iron deficiency, anemia, and weight loss and aspiration. How to diagnose that? Endoscopy with biopsy or CT for staging. Okay, this is easy one, just to memorize it. A very important one and very frequent in the exams. So we have here a 76-year-old man, okay, is admitted to coronary care unit after an episode of substernal chest pain. His other medical problems: hypertension, hyperlipidemia, type 2 diabetes mellitus. He has a history of diverticular bleed 2 years ago. After initial workup, we have cardiac catheterization. We see it 70, 100%. Left main, good stenosis, not good, sorry. 19 in proximal stenosis and 18 in right stenosis. So not good at all. We stopped the antiplatelet and the patient is continue on heparin drip for a coronary artery bypass in the next day. 5 hours after the catheterization, blood pressure low, pulse high. He complains some generalized weakness, back pain, but no chest pain or shortness of breath, nausea, abdominal discomfort. On physical examination, he appears diaphoretic, clammy, neck veins flat. So no problem in heart sounds. Chest clear. Right groin puncture is mildly tender in the right groin. Okay. No bruits or anything else. He received 1 liter normal saline and symptomatic improvement. So just we need the cause of this low blood pressure. Now a little bit elevate in blood pressure. Pulse good. His ECG no change. So what is the best next step in managing this patient? Okay, let's think a little bit. Should we do chest CT without contrast or with contrast? NG tube placement, start or C transthoracic echo, or urgent coronary bypass surgery. When you see like this, you do a catheter and low in this blood pressure without any obvious problem in the chest. Okay, not at all. So just do CT scan without contrast. Why? What is the link with that? Because it could happen with retroperitoneal hematoma. Oh, why? Because this is this patient's presentation is consist with retroperitoneal hematoma because bleeding due to bleeding from the arterial access site. Okay, local vascular complications, bleeding, hematoma, atrial dissection, acute thrombosis, pseudoaneurysm, are the most common complications for catheterization. All of that, please memorize them. Most hemorrhage or hematoma occurs within 12 hours of catheterization. Okay, so what we should do? We should do, first present with sudden hemodynamic instability and ipsilateral flank or back pain. The diagnosis is non-contrast CT scan. Okay. Treatment supportive. Okay. with intensive monitoring, bed rest, etc. Maybe we can do surgical repair of hematoma or retroperitoneal, but this is rarely required. Okay? No other problem, no need to do anything else. Okay? What about a disease called von Hippel-Lindau? This is VHL dominant. So we have always family history. We see hemangioblastoma in retinal or cerebellar, pheochromocytoma, renal cell carcinoma. Please memorize these three things. Hemangioblastoma, pheochromocytoma, renal blood carcinoma. So what we should do? Surveillance for malignancy. We should do eye retinal examination, plasma or urine metanephrine, looking for pheochromocytoma, MRI for abdomen, brain, and spine. If we see anything, just remove the tumor. Okay, so let me see if you have any problem. Okay, so, okay. We have 25-year-old man is brought to the emergency after high-speed motor vehicle collision. The patient was restrained, but there was prolonged extrication due to extensive vehicular damage. Supplemental oxygen and intravenous fluids were administered on the way to the hospital. On arrival, the patient is alert, can speak, but appears to have increased work of breathing. Blood pressure good, little bit low, but good until now. Pulse high, respiration high. Pulse oximeter low with 10-liter oxygen with mask. The trachea is midline, so no pneumothorax, no pneumothorax or hematome in the pleura. Neck veins flat, so we don't have constriction or compression. Pneumothorax, no cardiac tamponade. Okay, so it's not related at all. There are several chest wall and abdominal browses. A portion of the anterior left chest moves inward during inspiration. This is what we call paradoxical inspiration. Because in normal inspiration, the chest will go out, not inward. But here, it's inward. We'll see why. Breath sounds diminished on this anterior left lung, but normal elsewhere. The abdomen non-distended, normal. Left side deformed, but complements are soft and distal pulses are intact. So no complement syndrome. No focal neurologic problem. What is the cause of this paradoxical sign? This is the pathology for this. This is what we call flail chest, by meaning broken in the reps, but still related or attached to the lung. When the lung do the inspiration or etc., it's not goes with the normal way or normal range. So this is because of choice B, impaired generation of negative inspiratory pressure. Because when the normal pressure goes, the ribs goes out, the diaphragm goes low, so we have bigger in the size, and this bigger of size could cause low or negative pressure. This negative pressure take the air from the outside. I will repeat, this is the physiologic way or the normal physiologic response to inspiration. It starts with down with the diagram, out of the ribs. That could cause increase in size. This increase in size could cause low or negative inspiratory pressure. That's meaning we will take the air from the outside. because we have this flail chest or broken ribs, this area still with the lungs. Okay, so no negative in this part. So we have flail chest, higher than 3 contiguous ribs in 2 locations. So we have this paradoxical to the rest of the rib cage during respiration. Okay, this could cause ineffective ventilation, pulmonary contusion, and it could cause at end respiratory splinting and atelectasis, by meaning these lungs will not be open because always go inward, inward, inward. So the end, this lobe will be closed forever. Okay, because we don't have a rib that take it to outside. Always get inside. Okay, so what we should do for that? Just surgery to fix that. Okay, this is the pathophysiology. The other choices are not related to this case. Okay, okay, let me see if all goes well. You are welcome, doctors. If there's any problem, just let me know. Okay, so we have a 29-year-old man comes to the emergency department with persistent vomiting and abdominal pain for the last 24 hours. The pain is crampy, diffuse, and getting worse. He had a normal bowel movement 3 days ago and has no diarrhea. The emesis appears green without blood or coffee grounds. No blood or coffee, so no bleeding. Okay, so just we have vomiting and abdominal pain. Uh, we have the patient has not eaten since the onset of the pain because of nausea, no fever, by meaning no infection, pulse good, blood pressure good, while while standing low. His abdomen distended with hyperactive bowel sounds. In percussion, we see tympany, and the patient is diffusely tender to palpation. No rebound tenderness or guarding. Hematocrit good, leukocyte good, all good. Okay? Which of the following historical findings we will see it on the patient? We'll see appendectomy 6 months ago, or fatty food intolerance, or high alcohol consumption, occasional black or tarry stool, or recent fever or recent weight loss. Okay, because we see crampy and getting worse and appears the MSS green. So the green meaning uh, uh, bowel obstruction. Okay, this is the important one. How to know this is bowel constriction? Because in addition to that, we see the hyperactive bowel sounds. Okay, and the abdomen is distended because we have lower obstruction, so the fluids accumulate. After that we'll see the emesis. Okay, so what is the cause of this obstruction? An easy one, appendectomy 6 months ago. Okay, this is because of adhesions after the surgical for appendectomy. Okay, so we have small bowel obstruction. Okay, this is the adhesions, by far the most common cause of SPO. Always look for that. It's not congenital, not inflammatory, not etc. No, that's all. About the other choices are related to internal medicine problems. Okay, so we talked about them previously, about fever, Crohn, weight loss, fatty foods, etc. All that related to internal medicine, not surgical problems. Okay, very important problems in the athlete. Okay, we have what we call anterior criticate ligament tear that happened with this tear with a sprain in a rotational problem. Okay, we'll see this ACL tear. What about medial collateral ligament injury? We'll see it. The medial lateral when we have a problem on the direct of impact on the lateral. I will repeat. The tear in medial meaning hit on the lateral and vice versa. When you see problems come from the medial, that is a rare one, that will cause a tear in the lateral collateral ligament injury. Okay, important, tricky, but easy. What about a calculus cholecystitis? Very important in the complication in the hospital. The risk factor for this acalculous cholecystitis, by meaning you see this inflammation, but no something, no stones, etc., happen with severe trauma or recent surgery, prolonged fasting, or total parental nutrition. Very, very, very comes with this TPN. So please, when you see a long TPN, look for stress ulcer, look for a calculus cholecystitis, or it could be sepsis or ICU. What we will see, fever, leukocytosis, high in a liver function test, and right upper quadrant pain. We'll see jaundice, but and REQ much less common. The most important one, the fever and leukocytosis. How to diagnose? We will do ultrasound. We will see the inflammation on the cholecystitis or see edema in the gallbladder wall. We'll do HIDA or CT if needed, but no ultrasound is enough. How to deal? Antibiotic, cholecystomy for initial draining, or cholecystectomy once clinically stable. Okay, so by meaning this is surgical one. Antibiotic, it's not that enough for the treatment. Okay. What about gastroesophageal moral injury? It could be Mallory-Weiss or Perhaps syndrome. Please memorize them. All of you make screenshot or take it a photo by your phone and always memorize them as much as you can. On Mallory-Weiss, we have forceful retching. We will see mucosal tear just, submucosal venous or arterial bleeding. We'll see pain in epigastric or back with hematemesis and possible hypovolemia. All by meaning hard in MSS. What we should do? Upper GI endoscopy. Okay. What we should manage that? Acid suppression must heal spontaneously. No need to do anything else for Mallory-Weiss because it comes after a lot of vomiting attacks. So this Mallory-Weiss comes with hematemesis. What about Perhaps? No, it's transmural tear. So it's more deep than Mallory-Weiss. We'll see spillage of esophageal air into surrounding tissue, by meaning all the material or fluids in the esophageals goes out. So we'll see chest, back, epigastric pain. In addition to that, we'll see Hammond sign. The Hammond sign, it's crepitus and crunching sound. This is the must indicator for Perhaps. In addition, odynophagia, dyspnea, fever, sepsis, illness appearance, ill appearance, sorry. Okay? What we should do, if we do chest x-ray, we could see pneumothorax, pneumometastatinum, pleural effusion. If we do CT scan, we'll confirm the diagnosis. We will see the tear. What we should do? Emergency surgical consolation, MPO, antibiotic, acid suppression. But this is very urgent case. We should do it as fast as we can. Okay? Just let me see if there's any problem. Okay. Okay. So, what about emphysematous cholecystitis? What we'll see here, we'll see fever, right upper quadrant pain, nausea, vomiting, but the most important one, by meaning emphysematous, by meaning we see air, and that air meaning crepitus in abdominal wall adjacent to gallbladder. When we will see this case in diabetes mellitus patients or vascular compromise or immunosuppression, if we do the AXR or abdominal X-ray, we will see air fluids or air fluid levels in gallbladder, gas in gallbladder wall. We can see Clostridium or E. coli, elevate hyperperitonemia, elevated unconjugated, mildly elevated ALT and AST. The treatment is surgery, okay, with Clostridium coverage by meaning piperacillin tazobactam. This is the treatment or gold standard drug of choice for emphysematous cholecystitis. Okay, if you see here the black around the cystis, this is the gas. Okay, we don't see it in the normal gallbladder. Okay, very important one, easy one, repeated one. 16-year-old boy is brought to emergency with abdominal pain. 2 hours ago, the patient was playing in a lacrosse match when he suddenly developed severe, persistent pain at right lower quadrant and nausea. He experienced no trauma, no fever, vomiting, diarrhea. The patient had similar episodes over the last 3 weeks after matches, but these resolved shortly with rest. But now, no resolve. No history of groin or scrotal swelling, no history, no medical conditions, no problem, sexually active, no problem, temperature good, abdomen soft, non-tender, non-distended. There is scrotal erythema and edema, and right hemiscotrum tender to palpation. The pain is worsened when scrotum is elevated. You see this? This is to differentiate between testicular torsion or epidermatitis. Okay? Because both of them will see this redness, erythema, edema, etc. But this sign, the pain worsened with when scrotum is elevated, so this is testicular rupture. Okay? So we don't have transilluminate, by meaning non-transilluminate, we remove hydrocele. Okay? Which of the following is most likely cause? We talk about it. This is testicular torsion. Okay? Very important or recurrent case in this adulthood age. Okay? Okay? So this is testicular torsion. Adolescents, we see the clinical features like we see it in the case. No blood flow in scrotal ultrasound with Doppler. What is the management? Surgical detorsion and fixation with exploration of the contralateral side. Always look to the another side, not just fix the rotated one. No, look to another one. If no surgery, we can do manual detorsion, but the best one is surgery. No surgery, we can depend on manual detorsion. Okay, so all good. Yeah. Okay. Here, you want? Okay, doctor. Okay, no problem at all. You're welcome. Okay. So, another problem. If you have anything, just let me know. Okay. So, we have here, let's continue. Okay. We have 18-year-old man is brought to emergency department after falling and striking his chest. He has been playing with interactive video game when he lost his balance and hit his left chest against the coffee table. The patient now has a moderate left-sided chest pain, worse with deep inspiration. He also feels lightheaded, by meaning loss of vascular tone or loss of blood supply. Always after, uh, by meaning fracture or any problem, streak falling, etc. You see lightheaded. This is very risk factor for hemorrhage. On examination, the patient appears uncomfortable and taking shallow breath, low blood pressure, pulse high, respiration high. Jugular veins flat. So, also, no pneumothorax, no tamponade, by meaning the blood isn't in this area, isn't something related to the chest. The blood goes out. The trachea midline, left chest intact, bruised the skin, and tender to palpation. Breath sounds, here the important idea. Breath sounds are present on the right, but diminished, sorry, but diminished in the left lung base, which is dull to percussion. Heart sounds good, soft abdomen good, not distended, not etc. So what is the problem? It's an easy one. This is intercostal vessel injury. Why it's not left hemidiaphragm rupture? Okay, because we see here the tender. Okay, the tender one, and this problem, it's not hemidiaphragm rupture. When you see left hemidiaphragm rupture, by meaning we'll see the stomach goes out to the lung, etc. Okay, so it's not happened at all. We see here this patient has isolated blunt. Okay, be careful. Blunt chest trauma, by meaning blow the chest on the table, but now have hypertension, tachycardia, flat. So this is hypovolemic shock. But because each half can hold up 40% of circulating, so we have here large intrathoracic hemorrhage. Okay? That can lead to acute hemodynamic instability, by meaning this hemothorax. This hemothorax with fractured ribs comes with intercostal vessel injury. So what we should do? We should do tube thoracostomy, which is sufficient to resolve many cases. Although if immediate chest is higher than 1.5 liter, emergent surgical thoracotomy is indicated. The number is to memorize. Okay? Please memorize it as much as you can. What we should do? We should do tube thoracostomy and emergent surgical thoracotomy is indicated. Okay? No other problems, no diaphragm dysfunction, etc. No, we don't see like this. Okay, so this is related to the blunt chest trauma. We see here the hemothorax. Okay, about varicocele, very important, very repeated in the exams. We see bag of worms in the scrotal mass, low in supine, high with standing and Valsalva maneuvers. So it's not stable. The change of position could change its appearance. We'll see subfertility, by meaning not not fertility or etc. No, just subfertility. Not that good, not that bad. We'll see testicular atrophy. This is the bad one. We'll see retrograde venous flow, tortoise, anechoic tubules to testis, dilation of this plexus venous. What we should do? Just ligation. Boys or young men with testicular atrophy. Okay? Maybe we can give support, ZAIDs, older men who don't desire additional children. If you don't need any children, just do ZAIDs. No, need children, etc. So we should do conidal VN ligation. That depend on the age. Okay? It's not uniform, the treatment. No, it's depend on age. Okay. We'll see the last one. Okay, for today. And as I mentioned, tomorrow will be another uh, session. Okay. We have 42-year-old man comes to the office due to back pain. Yesterday, the patient was moving furniture when he suddenly had sharp shouting pain in the lower back and buttocks that radiate down to the back of the legs. He took acetaminophen and rested, but the pain was persistent. When the patient woke up today, his legs felt numb, weak, no strain. He had strain to urinate. He has no chronic medical conditions, no medications, all good. We see lower lumbar spine tenderness, bilateral lower extremity strength a little bit low, but the ankle reflexes are absent bilaterally, by meaning normal. Okay? Sorry, ankle reflexes absent, not Pepniski. Sorry, ankle, no. So this is signs of problem. Okay, no reflexes. Sensation to touch decreased in perineal region and buttocks. Straight leg raise testing is positive. So what we should do? Okay, because of this back pain, I will repeat the important keywords. We have back pain after moving furniture. We see had sharp shooting pain, okay, that radiated to the back of the legs. We see no change in the pain, still high, strain to urinate, problem with flexes, with touch. So what we should do? For sure, choice C and D and E not that good, by meaning NSAIDs or bed rest or physical therapy. No, we need something to confirm the diagnosis, to look for tearing or surgical problems. So what we should do? Obtain MR imaging, by meaning MRI, to lumbar spine, because this is what we called Coda equina syndrome. This comes with large central lumbar disc herniation. When you see this large, so you have something problem, could cause this saddle anesthesia, by meaning sensation in buttock and perineum, and bilateral lower extremity. So this problem because of Coda equina syndrome. Okay, so we have severe back pain, saddle anesthesia, problem in bladder, rectal sphincter paralysis. So what will confirm this huge disc is MRI for lumbosacral spine. Okay, and by here we end the first session in surgery. Okay, I wish